Hi, my name is Shana O'Hara Farias. My chairperson is Dr. Gail Pitroff, and my scholarly project is on improving pain management in hospice. Pain is a common symptom at end of life. Approximately 2/3 of advanced cancer patients and 50% of patients with other end-stage diseases suffer from pain at end of life. Pain management at end of life is critical because pain can cause unnecessary suffering. Nurses play a vital role in pain management. Nurses are often the mediators between physicians and caregivers, and the nurse's role includes identifying pain through pain assessment, alerting the physician of uncontrolled or new pain, recommending treatment options, initiating pain regimen, educating caregivers on pain medication, and reassessing pain to assess the effectiveness of pain management. Support for this project. I had received support from this project from the Senior VP of Nursing and Care Management. The motto at the hospice organization where this scholarly project took place is "Gentle the Journey." Currently, they are below the national average for pain management scores on their CAP surveys. So there was an opportunity to improve patient outcomes and improve family experiences and expand the nurses' knowledge. This hospice organization regularly offers staff trainings and in-services in order to improve the knowledge of their nursing staff to improve patient outcomes. I received an organization's letter of support, and I also received Maryville University IRB. I also worked closely with the clinical quality and compliance nurse who helped me throughout the scholarly project. I frequently had support from my chairperson, Dr. Gail Pitroff. The purpose of this scholarly project is to improve pain management amongst hospice patients. The aims are to improve pain management scores amongst these hospice patients, to educate nurses on pain management, to educate caregivers on pain management. This is a quality improvement project. The significance of this project for nursing, as I discussed earlier, nurses are a vital member of the interdisciplinary team that helps with managing pain at end of life. Nurses work on the front line of hospice care, so it is important that we improve and expand their knowledge to help achieve the goals of care. This is important for healthcare because the aging population in America is expected to be over 72 million by 2030, most of which will have at least one chronic disease. And the future of our healthcare system can be inundated with caring for these patients at end of life. Currently, 68% of Medicare costs are associated with the typical palliative care patient. It is important that we help manage pain at end of life or in our hospice setting to prevent increased hospital visits that will inundate our healthcare system. This project is significant to our advanced practice nurses because these nurses aim to meet the evolving and changing needs of their patient communities and healthcare systems. And as we discussed with the emerging burden of the growing elderly population, it is important that these nurses have evidence from research on how we can improve pain management at end of life. The benefit of this project is to provide excellent care to patients at end of life by managing end-of-life symptoms, improving quality of life, supporting families throughout the dying process, educating families, and educating hospice staff. I did a literature review and found 240 articles that talked about pain management in hospice care. From these 240 articles, I was able to narrow it down to 10 articles. And within these 10 articles, I found 3 themes. The first theme was lack of proper pain assessment. The second was barrier to pain management practices. And the third was barriers to pain management specifically for families and caregivers. The strengths of these articles is that it helped identify barriers to pain management. Some of the weaknesses is that there was limited data gathered throughout the article's research. Some of them had no access to family, which ultimately led to a delay in data, and therefore data collection outside of its natural setting. Some of the limitations is that there was a small sample size, which led to lack of generalization, and a lack of funding, which led to lack of data being gathered. Some of the gaps of these literature review is that it helped identify the barriers to pain management, but never discussed how we can overcome these barriers. These gaps highlighted the need for research to identify how we can overcome these barriers in hospice care. The theoretical framework for this scholarly project is the Health Promotion Model by Nola Pender. This model focuses on health promoting behaviors to enhance a person's well-being. There are first individual characteristics and experiences. There's behavior-specific cognitions and effect that we need to acknowledge and overcome. And then there's a behavioral outcome. Nola Pender highlights the need for a commitment to a plan of action in order to have a health-promoting behavior. For this scholarly project, we worked with nurses to commit to a plan of action, which was improving pain management to lead to health-promoting behavior, such as improved pain management amongst hospice patients and improved pain scores. Methodology. I had conducted a needs assessment, and as I discussed earlier, I had noticed that our CAP surveys for pain management specifically were below the national average, which for a hospice organization is unacceptable. We need to improve our CAP scores to help manage pain at end of life. I also had previously done some chart audits for this hospice organization, and during my chart audits, I had noticed that nurses had used improper pain assessment tools, did not complete a full pain assessment, and there were barriers to pain management. The design of this scholarly project is a retrospective chart review. The setting took place outside the DC, in a hospice organization outside the DC area. Participants were 18 years or older and received hospice care, specifically pain management while on hospice care. Some of the inclusion criteria were patients who were over the age of 18, received pain management during the pre-intervention or post-intervention time frame, and also had a length of stay greater than 7 days. Some of the exclusion criteria included patients who had a length of stay less than 7 days, patients who did not receive pain management while on hospice care, patients who were 18 years or younger than 18 years of age, and finally, whether patients were discharged because of long length of stay or an extended prognosis, or were admitted to an acute care setting for pain management. The analysis plan for this scholarly project is to obtain data from the EMRs, specifically pain scores, and also to gather information from the CAP surveys. Funding for this scholarly project was completely done by myself, the student. It was roughly a little over $2,000, and that included a computer-based training website, which was the largest cost, and then pain management brochures to be printed and distributed to caregivers, as well as paper to print out the EMR list of patients, as well as wear and tear and a locked office. Timeline. So the pre-intervention time frame began July 1st, 2020 and went to December 31st, 2020. The educational intervention was distributed in January to February of 2021. The educations include the computer-based training for nursing staff, as well as the pain management brochure for caregivers that were distributed in their admission handbook. The post-intervention timeframe was March 1st, 2021 to August 31st, 2021, and then the data collection process occurred during that towards the end of that post-intervention timeframe into September of 2021. This is the data collection tool that was created by the researcher. As you can see, no patient identifiers were taken. All of the EMRs were listed as number 1, 2 to 75. I gathered data from 75 pre-intervention time frame and then 75 in the post-intervention time frame. I collected data at admission. I collected data at the post-admit visit, which typically occurs within 48 hours of admission, and then I collected data every month thereafter. I collected information on the data, the documented pain score, as well as the pain assessment tool and the pain management practices that were used. Analysis plan. So I collected data, as I discussed earlier, from the EMRs. I also collected pain management scores from our CAP surveys. I analyzed the data. The percentages are for the CAP surveys. They are reported in percentages, and I did not do any further statistical testing. I also conducted a Mann-Whitney U test that was to determine the significance of the pain scores from the at each pain episode from the pre to the post-intervention timeframe. Protection of human subjects. So there was no foreseeable risk for physical, psychological, social, economic, or legal risk that will result from this project. There was a prevention. I made sure to prevent breach of confidentiality. As I discussed earlier, no patient identifiers were gathered from the EMRs. Patient charts were given code, and I collected data only to that code. I also was given a list by our quality and compliance nurse for patients who had received pain management during the pre and post intervention timeframe. I accessed charts only that for patients who were on that list. The lists were kept in a locked cabinet that only I had access to, and then were destroyed at the end of the data collection process. The findings of this scholarly project. So the instruments and procedures. So I used a data collection sheet that was created by me. I used a computer-based training to offer education to the nursing staff. I did have a post-training quiz. The sole purpose of this quiz was to take attendance of nurses that attended or completed the education. There was also the pain management brochure that I created for caregivers. Data quality and adequacy. So I ensured that the education was provided to the nursing staff was appropriate to RNs or LPNs. I ensured that the education given to caregivers did not use any medical jargon and were written in a 5th grade level. And I made sure that all the information came from research. The ethical considerations, I ensured that there was no biases or prejudices in the education, and there was no recruitment or patient engagement at all throughout the whole process of the scholarly project. These are my descriptive statistics. So as we can see in the pre-intervention timeframe, the primary diagnosis that we had seen was cancer. The second most prevalent diagnosis was neuro, and the same can be said for the post-intervention population. Then below that, the bar graph, you can see that non-Hispanic white was the most prevalent race, followed by Black or African American. After those two, we also had Hispanic and Asian patients. The genders were pretty close. In the pre-intervention, it was 64% female and 36% male, and the average age was 77 in the pre-intervention. In the post-intervention timeframe, the gender was 49% female and 51% male. The average age of the post-intervention group was 79. Quantitative methods. So I had used a Mann-Whitney U test to determine the significance of patient pain scores during the pre and post intervention timeframe. As you can see, I collected data from 5 different pain episodes, and you can see that there's a significance in pain episode 3, 4, and 5. No significant noted in pain episode 1 and 2. The CAP scores, as you can see below, the light blue is the post-intervention, and the dark blue is the pre-intervention. So you can see there was an improvement in our CAP scores from the post-intervention compared to the pre-intervention time frame. There were 2 specific CAP surveys that data was gathered that focused on pain management. Those are the hospice team provided training about pain medication, side effects, and indications, and the second was patient got as much help with pain as needed. These 2 CAP scores are written as they are written to us for quality measures at our hospice organization. The CAP survey scores are anonymous and completed by caregivers. Outcomes. Intervention. So as we can see from the slide before with the Mann-Whitney and the CAP scores, I did have an improved pain management scores, but as I discussed earlier, the pain management scores had improved at episodes 3, 4, and 5. We can assume that this is because patients who received pain management education for a longer time ended up having improved pain management scores. With the CAP surveys, we also saw an improvement in pain management scores. Contextual elements. There was a lot of different things going on at the hospice organization at the same time as this educational intervention. So, for example, we had a new EMR, so nurses had to attend training and actually self-teach themselves how to use the new EMR. This also complicated the data collection process because the pain assessment forms were different from the previous EMR that we used during the pre-intervention timeframe. There was a lot of organizational change during the educational intervention. There was a restructure that led to nurses switching roles or leaving the organization completely and new staff coming in, which with new staff, they have a whole new trainings that they have to undergo. Big facilitators of this scholarly project was the Senior VP of Nursing. She recognized all of the changes that were going on at the hospice organization at the same time as this educational intervention. So she allowed me time to speak at a monthly nurses meeting to talk with the nurses on the importance of the pain management education and why we're doing the quality improvement project. Another facilitator was the clinical nurse managers. They supported this project and encouraged their nurses to complete the education in a timely fashion. Some of the barriers to this scholarly project was COVID-19. Unfortunately, with COVID, there were a lot of meetings for nursing staff that they had to undergo at the same time as the educational intervention. The meetings were based off of updated protocols, vaccinations, and of course the burden of caring for patients during the COVID-19 pandemic. A strength of this scholarly project is the pain management education. As I had discussed earlier, the pain management education led to improved pain scores in later pain episodes and overall improved CAP scores. A limitation of this scholarly project was the fact that there was a new EMR during the educational intervention. COVID-19 led to a lot of limitations, and there was a short length of stay for patients, which was a limitation. I had to go through a lot of EMRs to gather my 150 EMRs. There was a short length of stay primarily due to patients coming onto service too late because of COVID-19. Also, when patients did come onto service, they were very sick and had a lot of symptoms to manage, not just pain management. So that complicated some of the education. And interpretation. So as I had discussed earlier, we had seen an improvement in pain scores. So from what we can tell, pain education is important to caregivers and nursing staff, but it is beneficial when caregivers have access to the education for a longer period of time. Implications for practice and future research. So this scholarly project informed us that education is imperative to improve end-of-life symptoms, and that it is important that we include caregivers as our interdisciplinary team, as well as it is important to educate them on end-of-life symptoms since they are the primary caregivers for these patients at end of life. Implications for healthcare policy. This scholarly project highlights the need to ensure that patients have access to care, education, and medication at end of life in order to improve pain management and other end of life symptoms. implications for quality and safety. So our CAP surveys are our quality measures, and it showed us that routine education can help improve our patient outcomes. And it is important that we have an interdisciplinary approach to ensure that we have high quality and safe care for our patients. Sustainability and dissemination. So I had given my education, both the computer-based training and the pain brochures, to the hospice organization. So they plan to distribute it to the nursing staff routinely. Right now it's planned to do annually, and we'll continue to distribute the pain management brochures to our patients and our caregivers on admission, and our nurses will continue to utilize the brochures. The brochures are also added onto our online website to make sure that patients always have access to this information. So if we continue with the education intervention and continue with working with nursing staff and caregivers, we can see an improvement in pain management amongst patients at end of life. And these are my references. I want to thank everybody for listening to my presentation, and please let me know if you have any questions.